Hi everyone, thank you for coming to my presentation for the American Public Health Association 2022 conference. My name is Dr. Roger Wong. I am an assistant professor of public health and preventive medicine at Norton College of Medicine in SUNY Upstate Medical University, which is in Syracuse, New York. The title of my presentation today is Role of Neighborhood Physical Disorder and Social Cohesion on Racial and Ethnic Disparities in Dementia Risk. I have no relevant disclosures. So there's two kind of pieces of background I need to provide for my research study I'm talking about today. First one is regarding neighborhood. There's been quite a bit of research showing the link between neighborhood and cognition. So for example, there's a few studies that have indicated that neighborhoods with low SES has been linked to adverse cognitive outcomes. And there's also other work that has shown that built environment is super important as well for cognition. So for example, neighborhoods that have like walkable sidewalks have a protective effect on cognition because that enables like more physical activity. And there's also a ton of work that's shown that there are persistent racial and ethnic disparities in dementia risk. So especially among Black older adults, they have about a 2 times increased risk for Alzheimer's and dementia. And also Hispanic older adults have about a 1.5 times increased risk for dementia as well. But there's also gaps and some limitations in the literature on this topic. The first thing is that contextual risk factors for dementia are understudied, and that includes neighborhood components. And then when there even is research on neighborhood, I noticed that a lot of this research is sometimes cross-sectional, and also there's been a few systematic reviews that have recommended that future research looking at the relationship between neighborhood and cognition should integrate longitudinal measures for neighborhood. And then finally, even though we've known for many, many years that racial ethnic minorities have an increased risk for dementia, we don't really know what are the mechanisms for this phenomenon. And research that kind of looks at the neighborhood characteristics are especially limited for this topic. So that feeds into my 3 research questions or 3 objectives for the study. First, I wanted to see what were the differences in neighborhood physical disorder and neighborhood social cohesion by race and ethnicity. And then second, I wanted to see how neighborhood physical disorder and social cohesion were associated with dementia risk. And then finally, my third research objective is combining the first two. So I was looking at the intersection between race, ethnicity, and neighborhood and how they work together to have an association on dementia risk. My data is from the National Health and Aging Trend Study, which is shortened to NHATS. It's a longitudinal panel study of older adults 65 years and older. This is a nationally representative sample. They started collecting data in 2011, and they collect the data every single year. It's up until 2021 as of now, but I ended my data study window in 2019 because I noticed that they stopped collecting neighborhood data in 2020 onwards. And based on these 9 years of data for the study, I have about 5,000 older adults in this sample that are community dwelling, and they did not. And I removed people that had dementia diagnosis in 2011. And they also had to self-identify as either non-Hispanic white, non-Hispanic black, or Hispanic. My outcome that I was looking at was when they got diagnosed with dementia. It's based on an algorithm in the NHATS that you see here. I'm not going to go into it, but I do want to talk about the prevalence of incidence of dementia here. So during this 9-year window, about 28% of the sample did get an incident dementia diagnosis. So you can see that most of these cases were among Hispanics, followed by Black and then white older adults. So for my neighborhood measures, again, I had the constructs of physical disorder and social cohesion. Each of those constructs are based on 3 questions in the NHATS. So for physical disorder, it's based on litter, graffiti, and vacancy. And then, in physical disorder, each of those 3 questions go from a 0 to 3. So 0 means none and 3 means a lot. And similarly for social cohesion, this is like knowing, helping, and trusting people in your neighborhood. That goes from a range of 0 to 2. 0 means do not agree, 2 means agree a lot. So for physical disorder and social cohesion, I created 3 separate composite scores. The first one was a baseline composite score for physical disorder and social cohesion. So pretty much I added up the 3 questions for each of them separately. So that's why the baseline composite score goes from 0 to 9, and then social cohesion goes from 0 to 6. And then follow-up is my other composite score I created. So pretty much this is the 0 to 9 or 0 to 6 score at the year right before they died or dropped out from the study, or they were diagnosed with dementia. And then my final composite score is change. So essentially I just did their follow-up score minus their baseline score, and I did that for physical disorder and social cohesion. There's a whole lot of covariates I included in my model and related to socio-demographics and health. So because my outcome is time to dementia diagnosis, I used survival analysis because my event is dementia diagnosis again. So for my main stats, I used Cox models, and I also applied complex survey sampling weights to make sure my results are representative of the US population. So I had 5,000 older adults in my sample. Majority of them were white, followed by Black and Hispanic. Average age was around 76 years old. So I know there's a lot going on here in this table, but these are my bivariate results comparing racial ethnic differences in physical disorder and social cohesion in their neighborhoods. So basically, starting with physical disorder up here on top, we can see that there's significant differences by race ethnicity for baseline physical disorder follow-up and also change. So starting with the baseline physical disorder, we see that Black and Hispanic older adults have a significantly higher levels of physical disorder in their neighborhoods at baseline in 2011. And then a follow-up, so again, that's the year right before they dropped out or died or diagnosed with dementia. They also had higher levels of physical disorder at follow-up compared to at follow-up. And then the change is the last one. This is again comparing follow-up versus baseline. And we can see that in general, it seems like on average the sample actually has a less physical disorder at follow-up compared to baseline. With the one exception is the Hispanic sample. They had slightly higher levels of physical disorder at follow-up compared to baseline. And then what about social cohesion? There's significant differences for baseline and follow-up, but nothing for change. So we can see that for baseline social cohesion, Black and Hispanic older adults, lower social cohesion in their neighborhoods. And then at follow-up, they also have Black and Hispanic older adults have less social cohesion at follow-up as well. And then for change, we can see that kind of later in life compared to earlier in life. In general, on average, the sample has a little bit more social cohesion at follow-up compared to baseline. And we can see that there's actually more social cohesion for the minority older adults, and it's even highest for Hispanic older adults. So I thought this was quite interesting that it's kind of differences in change for physical disorder and social cohesion for Hispanic older adults. And then for my other research question, I was looking at how physical disorder and social cohesion are linked to dementia risk. So if we, and I only reported the baseline and change here, I removed the follow-up. So if you look at the p-values on the right-hand side, you'll see that there's only significant association for physical disorder and nothing for social cohesion. So specifically, if we look at baseline physical disorder in 2011, there's about 11% increased risk for dementia for those that are living in neighborhoods with higher levels of physical disorder. And then if you also have more physical disorder at follow-up compared to baseline, you have about a 10% significantly higher risk for dementia. And then if we, again, for the social cohesion, non-significant. If you look at the hazard ratio, it's pretty much close to 1. So that indicates there's not really an association, appears on dementia risk. And then finally, my final research question is I was looking at the how physical disorder and social cohesion interact with race ethnicity and how that's associated with dementia risk. So similar to my previous slide, social cohesion was not really linked. There was no significant interaction effects for social cohesion, but there was something significant for physical disorder for both baseline and change, and that was specifically for the Hispanic older adults. So Hispanic older adults that had more physical disorder at baseline in 2011 compared to white older adults, Hispanics had a significantly lower risk for dementia. And then similarly, compared to white older adults, Hispanic older adults that had more physical disorder at follow-up compared to baseline had a significantly lower risk for dementia. And I think it's a little bit more interpretable if we look at the graphs for this. So I know there's a lot going on here, but there's really only 3 lines that I really want to point out, which are the 3 colored ones right here. So how to interpret this is that the higher you are in the graph, it's better because it's like slower speed to dementia. So we can see that, as I mentioned on the previous slide, Hispanic older adults that had the highest levels of physical disorder, they had the slowest speed to dementia diagnosis compared to black older adults, and white older adults had the fastest speed to dementia diagnosis when they were living in neighborhoods with high physical disorder. And then if we look at change for physical disorder, so this is again, I was looking specifically at highest levels of physical disorder at follow-up compared to baseline. And again, Hispanic older adults have significantly slower speed to dementia diagnosis compared to black and white older adults. So these 3 bullet points here are just wrapping up my conclusions from my 3 different research questions. So my first bullet here I'm talking about how it's the physical characteristics of the neighborhood and not the social components that appear to be an important social determinant of health linked to our risk for dementia. And then secondly, from the bivariate table I had shown, it's very clear that racial ethnic minority older adults have significantly higher physical disorder and significantly lower social cohesion in their neighborhoods. And then finally, from my the interaction graphs and table I showed you, I think we need some further research to better understand why racial ethnic minorities, even though they're living in these neighborhoods with high physical disorder, they seem to have lower risk for dementia. And especially if we looked at the Hispanic older adults in the last 2 slides, I think we need some further research to understand why we're seeing this. And my thought is, so unfortunately I had to remove the Asian older adults from the sample because there's just too few. But I was thinking, when I used to live in a Chinatown for a couple of years in New York City, and that's considered to be an ethnic enclave. And I just remember in my apartment in Chinatown, it was just the physical disorder was off the charts. There was just so much graffiti on my door, on the walls, sidewalks are just awful. And despite that, I felt like I was in a really protective environment because I was just surrounded by people that looked like me, and I felt like I couldn't trust them also. So I felt like there was kind of higher levels of social cohesion in that particular ethnic enclave. So we know from previous research that compared to white and black older adults, Hispanic older adults are more likely to be living in ethnic enclaves. So I'm thinking that it's because Hispanic older adults are more likely to live in ethnic enclaves that despite even the high physical disorder in these ethnic enclaves, like what I experienced in my Chinatown, it was still protecting their cognitive health. So that's kind of my theory on why I think we're seeing this finding. So that is it for my presentation. Thank you very much, and feel free to email, tweet at me if you have any particular questions. Thanks.